My approach is as follows. If they've never had a full evaluation, say, let me talk about, if they've never had a full evaluation, it's one thing. If they've already had a full evaluation, it's another. First of all, if they've already had a full evaluation, they're coming to me with a diagnosis, I do not look at the report before I do my evaluation. And I've become very much a stickler about it. It makes parents really frustrated with me sometimes, but I see so much that I wouldn't diagnose these days with autism that I feel really strongly that I don't want to be swayed by that. I want to look at a child, I want to do my own assessment, and I want to really look. Unless, the one unless there is if they have some rare genetic syndrome, which I see a fair amount because people seek me out for those things. If they have a rare genetic syndrome, I want to know about that and why people think, or if they've had genetic testing and that's been confirmed by genetic testing, because my testing isn't going to be helpful for them. But if it's a behaviorally based diagnosis that they bring, I want to be able to approach the child without all that background.
You're not just looking at the instruments they use, so that you're not re-administering.
That's the one thing I will do is say, when was the last time you had testing? That's the one question. If a child is under 6, unless I suspect MR, I hate doing the WIPSI. And again, I participated in the norming of that instrument. It's much better than the prior WIPSI, but it's still so fluid, I think it can be totally misleading to parents. So unless I really suspect it's MR or I need to rule it out, I try to stay away from doing an intelligence test for a child under 6. There's a reason kids don't go to school under 6. Sometimes you have to do it to be able to rule out MR or not, but I feel it's still very fluid. My clinical interview before the parents hit the door, they download it off of my website. It's 15 to 20 pages. I do a full symptom interview. I want a full clinical history. I want a family history. That's the only thing they walk in through the door. And I'll flip through that quickly and I'll have them bring reports before I start to do an assessment. Parent comes in. If it's a non-neuropsych, okay, if they think it's autism and the child is under 6, I start with this. One, because I can get such good rapport with kids with this instrument that I can warm them up pretty quickly. Now, it may be all I get. No, I'm sorry, the ADOS. Okay. Yeah, sorry, thanks for clarifying. So I start with the ADOS because it's so play-based and they're so loving it. Now, the problem is, as you know, they get so wound up with it sometimes you can't bring them back down. So I'll do the ADOS and then maybe get from the parents, I'll sit with the parents for a while. I'll do the social communication questionnaire to quantify a few things as a good screening instrument. I'll also get the behavioral and emotional screening system or the full BASC. So that's the first visit. If they're under 6, they're coming in probably for 2 or 3 visits with me. At that point, I'll give the parent a bunch of questionnaires to take home. I will give them the ABAS, which we're going to talk about in a minute, instead of the Vineland. Vineland, technically, you're not supposed to give to take home. The Vineland is an interview-based instrument, and that's how it's normed. And it is technically not within the good administration guidelines. People do it all the time, but that's not how it's meant to be. I find the classroom or daycare provider form for the ABAS to be much more user-friendly, too. And so I get good feedback. I'm about to publish a study and looking at 3,000 kids, screening over 3,000 kids, that found that parents over-reported and teachers under-reported. And out of the 3,000 kids, they were only consistent in identifying 8 kids. So they only agreed on 8 kids out of 3,000. Parents identified way more problem behaviors. Teachers identified way less. So moral of that story is get parent and teacher reports, and if a teacher says something's wrong, listen to them because they tend to underreport. Very surprising finding, I found. And they had a really hard time, sorry?
I was saying usually it's the opposite.
Yeah, and finding, I mean, this really held up in a sample. My sample was 2-year-olds to 8-year-olds, going out to the Journal of Pediatrics this month with those data. And we really found that, you know, if the child wasn't a good sport, or if the child was mean to other kids, those were 2 hallmarks. And the younger they were, the more significant those behaviors were on the behavior and emotional screening system. If the child's younger, I tend to use both, and my data are starting to show that in the 3,000 kids I looked at. For older kids 8 and above, who I still use, I probably would not use the social communication questionnaire and go to the behavior and emotional screening system. I find that people are either trained on the BASC or the CBCL. I'm a BASC girl. The behavioral and assessment scale for children, I love. I mean, I just find that the data from that are really right on. Teachers love it. The BESS, which is the form that is the shorter form, and again, we can go online and look at that if you all want to look at that after the break. I find that that form with 35 questions is incredible with teachers. The 125 version form I give if there are more problematic behaviors, but it takes more of teachers' time, which is the reason I put the teacher version form on my system. That was, it takes 10 to 15 minutes for a teacher to fill out. Most teachers are fine with doing that. Looks at internalizing disorders, externalizing disorders, but you need to get both. You have to get parent and teacher report. I digressed a little bit. So I'm going to give the BESS and the BASC, and or the BASC, and the social communication questionnaire, and the ABAS. I will probably give the pervasive development behavior inventory and possibly the social responsiveness scale. I start to look at how big I start to see after the first session the social impairments. So I load them up with rating scales. Then I decide if I'm going to give the Bailey, or if I'm going to give the shortened Bailey, the neuro screener, or am I going to give the, come back to me in a minute, I'm blanking on the name. Let me talk about the lighter and I'll come back about the other one I give all the time. Mullen? I don't give the Mullen. I'm not in love with the Mullen, but the Mullen, I'm glad you brought that up. The Mullen in this population has more studies published with it, which I find really interesting. So the pervasive development disorder behavior inventory, the social responsiveness scale, all of which we're going to both talk about those in a minute, to start to quantify social relationships. So I load them up and then I decide the DRS, the developmental rating scales, or the Bailey, or there's one other one I give and I'll find it, it'll come to me in a moment, that are really, I think, better than the WISC for 6, 7, or 8 for quantifying. Now, let's talk a little bit about the lighter. So the lighter is a more nonverbal test of intelligence. And I find that the results can be really misleading for families because a child will come up with a higher score, and that's great, and it may give us a more pure measure of intelligence, because everybody remember what the WISC is measuring, right? Kids who are not, it was developed to distinguish kids who are MR or not. That's all it measures, and it's become sort of used as something else. Now, under RTI, there's really a question about whether you have to give it, and I've worked in school districts lately that don't give an intelligence measure and only give parts of tests like the DCAFs or other tests, I'm sorry, Dellis-Kaplan Executive Function System. They've gotten away from giving the IQ test, and we can talk about the pros and cons of that. But I find that the lighter, if you're getting a higher number, but you're trying to educate the child within the mainstream, it's a really misleading thing because our school systems are so language-based. If you're getting a high score on nonverbal, how does that help you understand how you're going to educate this child within the mainstream if that's the goal of the parents? Now, one of the biggest debates is, should you pull these kids out and put them all in a separate classroom or a separate school? Or do you try to push them in and educate in the mainstream? Huge divide in the parent community, okay? I think it depends on the school district, on the classroom. You're finding more and more districts, because of costs, not paying for private placements for these kids outside where they might have. They're trying to pull these kids in, educate people within the district, and trying to work with these kids in the mainstream classroom. I think that's incredibly hard for the lower functioning kids.
They have special teacher credentials for that.
That's correct. Alliant has a great program. In fact, it's one of the places that has a great program for that. So, you know, from my perspective, I think it's incredibly hard, especially if a child is lower functioning. I really try to encourage parents to push into a special classroom to get them cooking and say we can try to mainstream later, supplement with a social, but really try to keep it focused at the first part. So my instruments then guide that decision making, so I tend to shy away from the IQ and go with more strength-based instruments where the Bailey and some of those other instruments will give me those strengths. And that's why I go with those instruments. Really, really important to use an instrument. I'm actually going out with an updated version of the slide and the article I'm sending to pediatrics this week. 30% I've identified without tools of kids who have developmental disabilities. This is by pediatricians, folks. If you get a good instrument, 70 to 80%. Amazing, right? We think we can do it, just like we'll recognize it. You gotta give good instruments, really important. Same thing with mental health issues, only 20% identified, and these are all the sites for that. Without an instrument, 80 to 90 if you use a decent instrument. So really, really important.